Well, thank you all for coming, and want to welcome you to this is our fourth workshop in an ongoing series of What's Philosophy Got to Do with Your Health? And so I want to welcome you again to Doctor, Tell Me What to Do, and, whether that's even possible, and a philosophical guide to medical decision making. And I'm very thrilled to be able to be joined here, who I'll introduce in a bit, a colleague of mine, David Gary Smith, a doctor from Philadelphia. And I will go through it. So, just in some ways to frame this conversation and what in some ways has motivated my interest in this field is that I began to notice maybe about 15 years ago probably that the character of my conversations with, I'm a general internist practicing in Brooklyn in right now a hospital-based practice, but I've been a physician practicing general internal medicine and teaching general internal medicine for 45 years. And what was striking to me was that my conversations that I was having with patients were undergoing a rather profound change. And people were coming to me not saying, tell me what to do, or I want to know more about hypertension or diabetes or this or that, but rather, what do you think I should do? I have this opinion, that opinion, I read that, I've looked up this, I've called a hotline, I have all these sources of information. Now, what do I do with that? And so these conversations were much more about what to do or how to create something with all of this information about medical choice, as it were, or medical uncertainty as all this information. Some people would call it information overload, if you if you want to. But it was much more about that than it was about what I know. People were not coming because I knew more than they did. In fact, many people that come to see me probably know more than I do about some things because they've done a lot more research. You're laughing because this patient back there that does research. And this isn't, it's very pervasive, I found. It wasn't simply about a complex, I have cancer and I have to really do, I have all these choices. I mean, it's like whether I should take penicillin or herbs for my cold, or everyday choices as well as very extensive choices. And, there's many accountings for this change, but I think that it could be in some ways summarized as there's been a profound, I think, democratization of medical knowledge. Through the, cyberspace, people have been able to access the full range of medical information that physicians or other provider caregivers have access to as well. And it's not just looking it up on the internet. I mean, I'm confessing that I prefer to read most medical journal articles in the New York Times these days because it's out sooner, it comes out before the article does, they give a better coverage.
The Wall Street Journal is much earlier than New York Times.
Oh, okay. But that's it. And then, there's just enormous possibilities for people through self-help groups. You call your hotline, the leukemia hotline, and the people that are working there have very sophisticated access to all the different treatment approaches. So I think that's the patient rights movement or empowerment movement has had a profound impact on this as well. And what, though, in some ways this has meant is a much better informed patient. And it might look different than in inner city Brooklyn or, middle class Brooklyn Heights, but it's very similar in terms of people are more informed and they come in and they want to know what to do with all of that. And added to this mix, though, is as you're kind of exposed to the information, you're also exposed to all the contradictions and all the conflicts and all the, quotes, uncertainty of medical science. And it's extensive. And from whether you should have a mammogram, which is like, up for grabs right now, whether you should have this radiological study or that radiological study, and when you do get them, they're never normal. I mean, I never get a normal CAT scan, for example. It's always got this little equivocation, that little equivocation, and you should have that study. So that's kind of what the consumers, as well as physicians, are sort of confronted with at this point. And what do people do in the face of that? Well, a lot of what seems to me, if you read the articles or talk to me, it's sort of like you choose. Okay, consumer, you have all this information, you just choose. And I think, I believe in radical democracy. And I think that patients, an empowered patient, should have that right to choose. And I don't think, though, as a professional, that I should opt out and just say, you choose. I mean, people come to you, because they value your opinion, they want to know what you think. And so that kind of creating a choice is something that I feel very obligated to do and want to do in the face of the extreme uncertainty and the extreme amount of information and the extreme pain that people are often in. And so how do we do that? Because I don't think that, people are very skilled at this. Either doctors or when I talk about doctors, I talk about medical providers as a generic term. I think medical providers or patients are very good about talking about these uncertainties and choice. To me, it's a methodological, philosophical kind of activity. And it involves, I think, something closer to creating creating a conversation, and a conversation where people with many different skills, capacities, knowledge, not just of medical science, but of themselves, can come together and say, let's create a decision today. And it was that kind of motivated this conversation, because I think that this is something that we could all work on and find out more about and maybe think about differently. So I invited my new colleague, Dr. Smith, to come and have this conversation with me. And one of the things that was kind of interesting is Dr. Smith found me, mainly he sent me a letter and said, I hear you guys up here at the Eastside Institute, where we're sitting, are interested in philosophy and medicine, and a man named Lev Vygotsky, who was a psychologist, which has been very seminal or basic to what the work we do here in the East Side, which I'll mention more. And so this was about a year ago, right?
Yes.
So I wanted to invite him to, we've gotten together a couple times and found we had very, very similar interests and approaches, and so I thought I wanted him to come and to have this conversation. Dr. Smith is a graduate of, I'm reading this, Temple University, and completed his internal medicine residency at Barnes Hospital at Washington University, and then completed a Robert Wood Johnson Clinical Scholars Fellowship at Yale University. And that's a very prestigious fellowship, if people don't know. And he's currently the Director of Graduate Medical Education and Program Director of the Internal Medicine Residency Program at Aberdeen Memorial Hospital, and a clinical associate at Temple. So the format we thought that we would use is I'm going to invite Dr. Smith to talk a little bit about how he sees medical decision making. I will talk a little bit, and then we will have a conversation with you. So you're on.
I'm on.
You're on.
Well, I was called Susan today and said I can't do this because it is such a difficult topic. It really is. There's an element of the Wizard of Oz syndrome. Don't pay attention to the man behind the curtain, and we like to stay behind the curtain. And we talk about uncertainty. There's a framework that good epidemiologists, decision analysts, of which I would consider myself not a good one, but that was my training, that you never look at just uncertainty. That you really need to look at it in terms of as a 2x2 concept or matrix. But when you talk about uncertainty, it's the lack of knowing about a specific topic, whether to do arthroscopy for knee surgery, whether it's to do a mammogram for breast cancer, whether it's to do a PSA for prostate cancer, whether it's to have a surgery on your heart in terms of bypass as opposed to other medical alternatives. So there's all this uncertainty about what needs to be done. And obviously patients and families want some clear guidance in terms of what should be done. And your partner's in the process, there's no question about it. Any physician that doesn't engage you as a part of the process, I would tell you, you should find another physician. Jerome Groopman said it right in his book. So anybody who's afraid of questions or afraid of internet information you bring in, that should be a red flag that you're not going to the right person. I'll say that. Can you edit that out, by the way? So when I look at uncertainty, there's a concept called reducible uncertainty, right? Which is, as a physician, you don't want to be in because, if you're uncertain because you don't have enough knowledge, enough skill, enough experience, that's not good for your patients, right? But no matter what you do, by and large, all decisions are fraught with the concept of irreducible uncertainty. Right? So there's a real difference in uncertainty we're talking about that you just don't know enough or you don't have enough experience, right? As opposed to having all the knowledge in, right? And I'll read a quote from a very famous physician, mathematician in this country, David Eddy. I don't know if anyone's heard of David Eddy, but he's the king of medical decision-making and statistics. And David wrote, not too long ago, that uncertainty creeps into medicine through every pore. So anybody that takes a dogmatic stance on any questions you have to deal with, you really have to be somewhat curious about what permits him or her to have that kind of certainty. That brings me to the flip side of uncertainty, and that's certainty. So I don't know if you all deal with physicians or healthcare givers that come across with dogmatism. So there's reasonable certainty, and there's unreasonable certainty, right? So the two cells you don't want to be in is in unreasonable certainty, where you think you know, when in fact you should know better than you don't know. That is a huge number of practicing healthcare givers in this country, period. And you don't want to be in the reducible uncertainty, because it means you haven't done your homework, right? Irreducible uncertainty and reasonable certainty are reasonable cells. Often, you don't know which cell you're in at times, and that's where the partnership becomes critical to the process, right? And we can talk about that a little further. Jay Katz, who was a mentor of mine at Yale, is a professor of psychiatry and analyst, and a professor of law, which is unusual, right? Wrote, I think he wrote this as a lawyer, but as an analyst. The denial of uncertainty, people who don't tolerate uncertainty, don't believe it should exist, the proclivity to substitute certainty for uncertainty is one of the most remarkable psychological traits that he's ever seen. We are educated for dogmatic certainty. And I'll tell you, Susan, to tell you that I'm also president of the program directors of internal medicine nationally. And we absolutely train for certainty. And that's absolutely wrong. Right? So unfortunately for you all, our graduates are not looking at the world through the prisms that they should in terms of really respecting uncertainty and certainty. And there's a hubris of youth. Right? Which brings me to my next point. And it's about the development of a clinician. Right? Early on, within a couple of years, a decade after training, which is residency programs, pretty much the graduates are rule dominant in terms of the way they make decisions. They go through protocols, they have recipes, the Preventive Healthcare Task Force, and so forth. So they lack the nuanced elements that are required for more sophisticated decision making. Pretty much that's about 15, 20 years into practice, right? And that's what you call a master clinician or an expert clinician. And that gradient is usually not respected. Most people expect, once we say they're graduates, they're ready to practice fully and competently. And that's a misunderstanding about where people are in the evolution. So if you can get someone who's considered a master, and sometimes masters are self-proclaimed. So you want someone who really is the physician's physician. In terms of, when you're dealing with difficult or second opinion or primary management decisions, right? The other thing, and Susan, I mentioned, I'm a really big proponent of patients and families searching the internet and bringing information. I think that's wonderful. And it should be democratized even further. And we should have, some sort of way of rating information that comes to you on the internet, because we could all point to some bad source information. So we will go into that, but that's one of the downsides of internet, that you have so much information, what do you pick? How do you pick from it? But there's a difference between information and knowledge. Reading something on the internet can educate to some extent, but it can never replace experience. So that's where you want someone to be able to take care of you that has experience. So if you go in with a difficult diagnosis, or a somewhat rare diagnosis, or somewhat controversial, I got a call last night at 10 o'clock from a friend of mine who was in Florida and is going through this, does she have vasculitis, which is inflammation in vessels or not, right? We had this hour-long conversation. And mostly it was, can she trust her physician? Right? And so there's key questions you want to ask about his or her management style to say, can you trust it? So she was thrilled at the end of the hour because he did all the right things. In this case, it wasn't he. And that was satisfying to her in terms of getting my second opinion, whether it was worth anything or not. Right? And that's a big deal in terms of, as we talk about this, in terms of giving you a sense, or giving her a sense, that this person had knowledge, not just information. He was making very good utility-based decisions with her participation. That's not always the case. So if the person hasn't seen vasculitis a lot, or other obscure diagnoses, that's not a person who I trust my care to, with all due respect. Right? I want someone who manages those conditions and feels comfortable. Because if you've not seen it, you don't know it. Right? That puts me as a physician, if I've not seen a condition, in a lay perspective. Right? You can only know a condition to management if you've seen cases with that condition. Susan and I were talking about this earlier in terms of, it also depends on what the model of relationships that you have with your physicians. Right? So I saw one of Susan's patients get on the elevator with us, and his eyes lit up and was bright. You understood that the model relationship that this person had with Susan was a pretty remarkable relationship, right? So the three models that I kind of talk about, although it's called different things, I'm going to use very simple nomenclature because I'm a simple guy. I'm a general internist, right? We're simple-minded. So there is the model of the doctor-patient relationship that I would call I-it. The I being the physician and the it being the patient. That's where the patient's the liver, the arthritic knee, the congestive heart failure. That you never really see a person sitting in front of you. Right? You see an organ, you see a disease. You see a myopic focus that really doesn't allow you to see the other sitting in front of you. That's something you probably want to avoid that. Maybe it's okay in a neurosurgeon, but you don't want that in the physicians who take care of you, especially in terms of in a longitudinal relationship. Then there's the I-you relationship, where the physician might see you as a patient, but not as a person. Right? So a little more perspective in terms of the forest, but not necessarily a broader perspective. Right? And then there's the Buberian concept of I-thou. That's where the physician and patient have a real bond in terms of a trust. Now, I'm going to ask you, I assume that all you have primary care physicians, is that true? Right? So if I ask you if you can classify your relationship with your primary care physician, right? And I said, okay, how many people are involved with a physician who really treats the clinical problems in an I-it model? Are there anybody here that would say that that's the model that the doctor-patient relationship? So you're an informed clientele. So there are a lot of physicians around to do that, so make no mistake about it. How many of you get into the I-thou relationship, where you have a real, strong connection with your physician? Raise the right hand. All right.
Are we talking about past or?
Current.
Yeah,
Correct. So that's where you have almost, there's no I, there's no you, there's a bond, there's an intersubjective. It's what Thomas Eidman calls the alloy third, and I like that concept, but it's an intersubjective. There's no real I in that, or you in that. There's a real bond in terms of walking this path together. How many of you have an I-you relationship with your physicians? Where there's really sort of not that connection, but so there's a little mixture between the two models. You'll see the I-it, and I tell you, it's out there. How you deal with the questions you're dealing with depends on what model you're in. So if I'm with Susan, and I really think I have an I-thou relationship with Susan as a patient, right? There's a trust there that perhaps that transcends the need to really be granular in the discussions about what should be done, right? It's what Schatzman from the Europe is called personalism. It's like is if that physician thinks there's nothing more important in that moment than what happens to you as a patient. That's the fiduciary bond. That's the obligation. If you get into an I-you or I-it, you have to be caveated. in terms of dealing with these types of issues of uncertainty and certainty. So with that sort of as a backdrop, I'm going to stop because I was told, Susan told me not to talk too long. See, she knows, And my twin sister's sitting in the back, and she doesn't want to hear me talk either. So I'm going to stop, because I want to hear what you have to say and the questions you have, in terms of whether anything that I have to say would be of relevance to what you're experiencing.
Thank you.
You're welcome.
I'm thinking about, because there's clearly a connection between how we think about this, and there's probably differences, and I don't know, I think I would like to just speak from the vantage point of what I think has been helpful for myself and patients working together in this arena of decision making. And because I think that what you're talking about in this doctor-patient relationship is how do you create that, or how do you shape that around these very complicated issues. And I think one of the things that I was thinking about that often I found we're doing in my work with people is making, in some ways, obvious that you are making a decision. And that there is something to talk about here to get to whether it's certainty or close to certainty or what. Because I think a lot of times people, you go to the doctor, and this is, because I have so many people that's happened to. You go to the doctor, they do their exam, and they say, here's an echocardiogram, here's the lab test, and I'm going to send you to the orthopedist for your back. And you take those and you do it. And, and then people tell me what they did, and they said, oh my God, you've just made huge amounts of decisions there. And it's not even clear that those decisions were made and what they mean or how they mean. So, in some ways, I think a lot what we work on together is that activity of what are we doing here? What is the decision we just made? Is there a decision to be made? Is there another way to think about this? And that's a continuous, ongoing activity that we're doing together. And I was thinking about, in preparation for this, I read the beginning introduction to this book, which is Fred Newman's book, who was the founder of the Eastside Institute, where we are. And one of these, he was talking about about the philosophy of decisions and things. And I want to read it because I really liked it, because it's in those very moments when we're caught up in the immediately pressing practical questions of everyday life, like, should I be buying chicken or hamburger for dinner? Here's this example. We need to recognize ourselves as the makers not only of hamburgers, but also of the ongoing creative social process that is history, which is the totality of what there is. And the point is not to know history, the subject, but to see yourself as a maker, a performer of history, the collective life that human beings create together out of what there is. And, I think that I found that to be not an abstraction in any way, but something that each of these times that somebody gives you the blood tests, or, go to see an orthopedist, or it's, I think, important for us to kind of see those as decisions that are being made. So if you're going to go for a heart test, there's probably 10 things down that road that the results of the heart test might show you that are going to pull you down that path of decision making. So I think that and choice and those kind of things. And I think that those are something that as the, people who are sitting on the other side of that, I think it is very important for, as patients, to be saying, well, even the blood test, what are you ordering? Why are you doing this? What does it mean? What are the implications of that? Or how is that going to fit into my needs and wants as a person? And that has an impact on, I think, how we see ourselves. And I think that's how I found one of the things that can be very helpful to my patients about is just literally thinking about what decision-making is, or what that process is, and how people can be more engaged in that process. I think the other thing that I found very, very helpful in thinking about decision is it's a continuous ongoing process, that the process of making the decision is inseparable from the decision. So that you, I think many ways, the more it's the, for those people that know that, tool and result activity. It's building the boat as we go across the water. We're constantly creating it, and as creators of this process and answers to our health issues, you will be doing that in an ongoing way, as opposed to simply saying, okay, I've got this piece of information, then I'm going to make choice A, B, C, or D. And I think that's what I found people can get some help with, is they don't have to make decision A, B, C, or D. They could say, let's put another brick in this process. It might be I'm going to go talk to another specialist. It might be I'm going to go do some more reading. That's where I found people often feel pressed to make yes or no, right or wrong. Okay. And there was one study that I heard presented at a conference, because collaborative decision making is a very big issue in medicine. People write about it, it's great, blah, blah, blah. And then there's a study that says 50% of people don't like collaborative decision making because they're afraid of making the wrong choice. And that's the way it's presented. You're either A or B. And I think that partly what this activity, or seeing decision making as an ongoing activity that we're doing with other people, and as many people we want to include in that as possible, I think. It doesn't necessarily, it has to go just in a dyad, gives you a sense of possibly doing the wrong thing and then doing the right thing. Or what's the urgency, or getting some sense of that. And I think that for people that go through that process, and even if you come out with, quotes, the wrong answer, you don't get where you want it to be, I think there's a certain amount of support from people that make those decisions, that you didn't do it right or wrong, but you're engaged in this activity and you can continue to build your health in an ongoing way, that maybe as you go along, you'll have accumulated a certain knowledge and a certain methodology and a certain approach that works for you. And I think that's the important thing. Maybe it wouldn't work for Mr. X, but it works for you. And people, that's where I think your preferences and who you are comes into that process. So I always think it's very, very important for people to be, as you say, to be involved in that process, because it's not passively but very actively in terms of how you want to do the process, not just the outcome. And if you want to slow the process down, if you want to have it go faster, if you want more people involved, I think those things are as important as how we come out on the other side, if there is an outside on the other side. And because, like even things like, are you going to have a mammogram? It seems to me has enormous implications for women who have, what's the implication of getting the mammogram? Well, you could have 25% of people are going to have an abnormal mammogram that doesn't mean anything. You might be pulled into a more surgical way, and you might decide, well, that's not the way I want to go. So I'll wait 6 months, and I'll decide at that point whether I want to have a mammogram. And so it seems to me that that's just an example of some of the ways that people can think about their decisions that are based on who you are, and not how, if we think about it as a static process. So that said, and then we're all decision makers, I thought we could just open this up. But one of the things I did want to just ask you about, do you really think that there is such a thing as medical certainty?
Rarely, rarely. I mean, and you brought up breast cancer. When I was younger, as part of the breast cancer demonstration detection project. Do you remember that project in the 70s? I don't know if you remember that. But what it was fast. It was the HIP study, health insurance plan study, demonstrated that there was a benefit to screening women above 50. How we got to 40 is a big discussion, but 50, right? And so the government did this demonstration project in terms of there weren't enough X-ray machines or radiologists in the country to make a recommendation all women above 50 get screening. So the question was, will women come in? And that was the breast cancer demonstration and detection project. Would women come into the programs? Well, they came in droves. There was no question they would come in, right? But an interesting sidelight about that project, and I was at WashU, which was the statistical center, that the women were handled in the communities, right? And if they had lumps on examination or mammograms, they would get biopsied. If it were positive, they go into surgery. And at that time, a lot of people were doing radical mastectomies. But as one of the elements of the project, right, the biopsy would have to go to a central pathologist in Washington. But it was after everything had been done, right? It was a post-hoc analysis of the pathology, right? What they found is that a considerable number of people that were told they had cancers in the outlying, regional centers didn't have cancer, but had treatment. So as a binary as it's either cancer or not, at the level of biopsy, that wasn't even, certain. So when you say, is certainty permissible? It's rare. There are certain conditions, obviously, if someone comes in with a 1 mass, 2 centimeters as a smoker, right, the likelihood ratio is infinity that that's going to be cancer. So there are certain elements in management that permit certainty. But the vast majority of things we're dealing with don't permit certainty. Which brings me to another concept, which I'll add, is the misplaced concreteness of numbers, right? Now, I don't know how many of you deal in numbers in terms of you see physicians, in terms of probabilities and so forth, right? And there's a temple where I'm an associate dean right now. There's a professor Polis who writes book after book in terms of saying that we're clueless when it comes to handling numbers. There's a profound epidemic of innumeracy in this country, right? And that includes physicians. I mean, physicians are turbo numbers. Absolutely, right? So, for example, often you'll come in and someone will say, you'll 66% chance of reducing your chance of cancer if you have this test. And they go, 66%, that's a pretty good number, right, Susan?
That's a good number.
So you'd say, I'll have that test, right? But in fact, that's not true.
I wouldn't listen to that.
Huh?
I wouldn't listen to that.
Well, but you wouldn't know it. You wouldn't know it, and I'll tell you, there's a good reason why, because everybody deals in relative risk reductions, which inflate the actual benefit, right? New York Times does it. Major media outlets do it, because it's selling copy. If I said there was a reduction of a 10% in your chance of having cancer, that's less impressive. But a lot of the tests we're talking about, have that kind of absolute risk reduction. So how many people have had the zoster vaccine, for example? The shingles vaccine?
Shingles vaccine.
Anybody hear of shingles vaccine?
Yeah.
Did they tell you how beneficial that is?
No.
All right. So
It was recommended and I decided to do it.
right. So you didn't even get into the uncertainty.
No, on
involved.
that one I didn't.
Well, let me ask you a question, and this is a hypothetical question. If I told you that vaccine reduced your chance of shingles by 66%, all right, would you feel good about the decision in terms of taking the vaccine?
Yeah.
What if I told you it was really the benefit, the absolute reduction in chances of shingles was 0.1%? Would you feel as good about
No.
the decision?
No.
There's another way you present data, too. Number need to be treated as everybody use this statistics, right? So for every one you want to benefit, you have to treat a certain number of people because not everybody benefits. So for example, the reason why you do the Zostavax or the shingles vaccine is really to prevent the dreaded post-herpetic neuralgia. That's the real reason. I have people come in all the time. I don't want to have what my friend had, the severe shingles with pain and this.
Right.
And I tell you, I wouldn't want that either, right? So I would have the vaccine, and that's about a 30% reduction in relative risk, right? I'll get the question for a second. But actually, if you look at it, you have to treat 1,000 people for every one to benefit from that vaccine. So that, the numbers become somewhat important, but a lot of people don't deal well with numbers because they don't understand them. And I'm going to tell you, my profession, and I would include, all healthcare professionals, don't understand the numbers. And what you're going to get is relative numbers. So anybody that gives you the kind of, it's a 30% reduction, 40% reduction, the first thing you need to say, is it relative or absolute? And they wouldn't know the answer to that question. So that's where your research would be important in terms of really finding out. Okay, so we had a question back there.
Well, about the shingles vaccine, of
Yeah.
course, I had shingles.
Mm-hmm.
Okay, I had facial shingles.
Mm-hmm.
It really wasn't so terrible, my attack. I just have a scar on it. And I recently went to an infectious disease. My internist said when he first met me, oh, maybe probably wanted money because I was started Medicare, and maybe they wanted to make some money on the shingles vaccine. But I said no, because my friend's son said, if you've had shingles, you don't necessarily, he's a doctor, don't necessarily need it. So I said, okay, I'm putting it off, and then I keep asking my friend what did her son say, and she had shingles, worst case. And then I said, you know what, I'm making an appointment with my infectious disease doctor. And I went to him a few weeks ago, months, and I said, I've had shingles, should I get the shingle vaccine? First he said yes, and then he said no. He said, it's a live vaccine, and with your immune problems, I would not. So everything is individual, even with numbers out there. And he said no. So I didn't get it, So, and now I have a friend or an enemy who recently got shingles, and she's suffering from shingles.
Well, and see, that's, not to go into all the details of your medical history, because HIPAA precludes us from having that kind of confidential conversation, right? But the issue is, to some extent, is what is required in the nature of the discussion in terms of having that decision. Now, I'm going to be honest with you. I don't think you can have an informed discussion about all decisions you make. Because basically there's not enough time, there's not enough energy. Most patients don't want to have it. They just want to say, do I need the vaccine, yes or no, right? To some extent, it became a little more interesting in shingles because it wasn't covered by a lot of insurances. So it cost $200 to $300, and for a lot of people, that's a big deal, right? So the bottom line is that, if you gave them the numbers as I just presented it, which I think I'm right from the New England Journal of Medicine, right? Most patients would say no, right? But then you're stuck with the regret people have when a patient shows up because you say it wasn't something you should do with a severe case of shingles, right? So that physicians tend to suffer from what's called Mailerism. What that is, that means we want to do things, right? It means
Mailerism?
Meliorism, Mailerism, right? So we want to do things. We don't want to, if we can give you a shingles vaccine, most people would give you a shingles vaccine. Right? Most infectious disease doctor would give you a shingles vaccine, right? And they wouldn't give up that kind of discussion with you because they don't think that would merit that kind of informed discussion, right? And there's also in the decision analysis literature, there's a thing called physician regret, right? We regret, this goes along with Mailerism, right? And it's actually modeled in these decisions. We regret more if we could have did something but chose not to do it, as opposed to if we did something and there was a complication. So almost everybody that I know of would err on the side of doing something because we are not just watchful waiters. We want to be aggressive. But that gets the people into complicated, issues. Now, I don't want to go into all the details, but, I can tell you that we recently had a case, my patient, right, with full disclosure to the family, where a CAT scan killed this patient. That she had a complication from the CAT scan, she died, right? Tragic, right? She didn't need the CAT scan. She didn't need the CAT scan. And we should have known that she didn't need the CAT scan. But the subspecialist in the case, and I'm blaming the subspecialist, not me. But I could have stopped it. But the bottom line is that the issue was he wanted to be certain about a diagnosis. And there was no reason to push that certainty. So that's the problem that we have to look at. You have to look at both sides. It's not just uncertainty. It's the pursuit of certainty, and you've alluded to this, in terms of all the unforeseen abnormalities that surface that require further workup, further complications. And it drives you crazy in pursuit of certainty. So certainty is just as much a problem in medicine as uncertainty. And you can't get away with it. You have to balance it. There's no way to escape the conflict between certainty and uncertainty of medicine. That's what frustrates all decision making.
This concern with certainty, is it not complicated by another concern of being sued for malpractice? You didn't do enough, you weren't certain. How does that affect your
Absolutely.
decisions?
I mean, it's in there, and certainly people, I think, it's not that it's not real, but there's about 1 million different studies that show if doctors have conversations like that, with their patients about what's going on and why they're doing things, their suit level goes down. So it's really a substitute for, I think, people doing not very thoughtful medicine myself. I mean, it's not that malpractice isn't real, but it really is pulled out of the hat for people to do these kind of no-think things. And I think what David is talking about is the harm of and the killing of the patient with a CAT scan is one thing, but the number of people that are, I think, harmed by being put through this certainty path is often creates more uncertainty and more sense there must be something the matter with me. If, I've got a CAT scan with a little something on it, you're walking around like that. Lou? Did you have a question?
Oh, actually, I do, yes.
Oh, yes.
Actually, I was just curious, first of all, how can you get killed by a CAT scan? How does that happen?
All right, so you asked. Basically what happened is she went down for a CAT scan to see if she had pneumonia, which was a trivial issue because there's other data to support that diagnosis. As she was in the CAT scanner, she had pretty significant gastric contents, and that was aspirated during the CAT scan itself and caused a widespread pneumonitis, and she died from that.
A widespread.
Inflammation of the lung.
Uh,
Right. So that was the complication in that case.
So you
And it
said
didn't have
you
to be
should
done.
meet before you have your CAT scan?
Well, that's actually interesting enough. We're going to get far afield. Actually, one of the quality protocols is that you shouldn't feed a patient before a CAT scan. You should have as little as you possibly can in the stomach because of the fact that most CAT scanners you're supplying, you're lying down. So, and that's one of the things that got breached in this case was that we failed to follow that protocol. All right, that she shouldn't have had the CAT scan. She did, but this is we do some of the CAT scans in my hospital. It was the only spot in the queue that she could get, and so they missed that quality protocol. And that's where another side issue in terms of the whole area of uncertainty is all about quality protocols. That as everybody knows, safety and quality is the mantra right now in the IHI, and Don Berwick, who is one of the biggest proponents in this country, has just taken over the governmental agency, the CMS, which is going to have a lot of things happening in the near future in terms of quality initiatives across the spectrum of healthcare, which could be very interesting to watch, to see if someone from the not-for-profit sector, an Institute for Healthcare Improvement, and he's done wonderful things in this country for quality medicine, moving into the government, whether he can have the kind of effect he had in the not-for-profit sector.
What's his name again?
Don Berwick, Berwick, and he's the god to me, in the sense of that he's been championing this since 1981.
I have a question. When you have a patient who is determined to do something that you may feel is dangerous for them, say somebody has a little lump and, I don't want to do a mammography, etc. Do you caution them as to the road they're taking if you feel from a medical standpoint that they're taking too much risk? How do you deal with that?
Well, I think that in some ways gets into this thing about whose choice is it. And, in some ways, in the bottom line, it's the patient's choice.
But do you let the patient know what your concerns are
Yes.
about the choice they're making?
Yeah.
That's the question.
Yeah, I think that's what it means to do a collaborative decision choice-making involves being able to have some kind of dialogue about that puts your, what you think and what you know and what the patient knows and what other people in that, it might be what your relatives are thinking or other people are thinking as well. It often is a much larger group, and a willingness to have that kind of dialogue or create that conversation and to accept what the outcome is. I had a, in the book here, somebody, Fred Newman, who wrote the book, and he made a decision that we all worked on, and people, when I presented it at a conference, they said, you can't do that, you should have left the case. You can't let people do things that are, destructive for them. You should have just said, I'm not going to be the doctor anymore, that's your and bottom line. And I said, no, my bottom line is to support people to do the kinds of things they want to do with their health with me, and I don't think that I'm the person, I don't think certainty, I don't believe in the rightness of it. I think what's right is where you can go in your conversation with somebody.
So if you had a
Your
psychotic person who believed that smoking cigarettes were going to cure their cancer, you would continue to treat the
Yeah.
person?
Well, I don't,
I mean, I'm really wondering,
Yeah.
taking a
Yeah.
real extreme,
yeah.
if a person had an idea like that, would you continue to work with the person?
Why would you abandon them? I
Okay,
don't see
that's what
any
I was
reason
just
to
trying to
abandon them.
understand where you
But to
were.
support your thesis, I mean, there are physicians who say to patients, if you don't stop smoking, I'm not going to take care of you.
Smoking what?
No, my point really is,
In Philadelphia, it's legal.
Pardon me?
In
Yeah,
Philadelphia.
but that's
I mean,
marijuana.
if
that's a
somebody
different
was
story.
doing something that you felt had a 95% chance of killing them, would you continue to support them, or would you not want to work with them?
To me, I would not want to walk out or abandon somebody, no matter what they do.
Okay.
This doesn't.
I was just wondering, because
Jessica, I was going to call you, but Kim had his hand up behind you.
Yes, with this new petition, democratization of medical knowledge, there's been a greater prevalence of patients coming in and insisting upon certain procedures.
Yes.
Well, when you look at, I don't know if you watch TV, but if you watch TV, if you watch for example, Super Bowl, right, the direct patient marketing in terms of getting tests or getting drugs is widely prevalent. So, I can tell you, we come across it all the time. We actually, it's died down, but there was in our center, by Forge, that they would do MRIs on any patient who walked in without a doctor's note. And it led to a lot of the false positives coming up, incidentalomas, led to a lot of grief, right? And now, I don't know if that goes on in New York, but that sort of died down in Philadelphia where patients can get their own CAT scans and MRIs, but that was also a part of a direct marketing, that people came in and said, I want my annual CT because I've been smoked at some point in the past and I'm worried about lung cancer, even though insurance doesn't pay for that. So there's all these direct patient marketing or patients on the internet coming in with, I want daily ceftriaxone for my seronegative Lyme disease for a year. And kind of go, well, how do you deal with that question? And that becomes a real issue in terms of sitting down and going through, why that's not a good idea. I wouldn't order that based on their interpretation of the information on the internet. There's certain levels that, I would take care of smokers no matter what, because it's an addiction, and I treat patients with addictions. But the bottom line is that I would not accede to a request to do therapy that really had no benefit.
But people come in all the time in response to this and wanting to do things that I think are dangerous or harmful for them. And I take an extreme view of this, like, I want a stress test. And, like everybody, you read about hearts and everybody read about stress tests and you want to make sure your heart is all right. And so they say, well, shouldn't I have a stress test? And, the amount of false positives are high in stress tests, particularly if you're just fishing. And what does that mean? It means you go have the next step and the next step, which is you end up with a cardiac cath, which is a rather dangerous procedure and a big deal procedure. And they might find a little narrowed artery, and some people would say you should have a stent, which is to put these metal things in. So there's a pathway that people often, and so to some extent, you have to have that conversation with somebody. And if the conversation can't be, I'm right, you're wrong. I mean, it can't have that character, because then you just create that adversary. So it seems to me you need that conversation, and some people, and a small number, will make that decision that they want that kind of certainty, and will say, I'm going to go for the stress test anyway. And I'll say, fine, we'll send you off for the stress test. And I don't agree with that, but I think that I feel it's important that we had some kind of ongoing conversation about that, and that's where we came to. And people ask for that all the time. So I think it couldn't be just, oh, well, that patient's silly, but they want the stress test, so I'll just give it to them because, they'll get mad at me or something. There's many different attitudes that go with that. But I think my feeling is you've got to have the conversation and that decision has to be ongoing and reconsidered and moving along. It's not simply yes or no.
I think there's a thing that
Sorry.
that comes into this, that what the patient has a chance to receive or to view is your strategy, what your thinking is explicitly. They come in looking for an object, this object's going to help. They have certain reason to think that it might, so that's their initial focus. But when you have a conversation and you evaluate not only that object, but other things that might affect the patient, the same thing they're concerned with, and suddenly they can see in a simplified way things as you see them, and then what are the choices that might be, what are the properties of each and the risks. And they're playing a different game at that point, and that's a much better game.
Well, I'm a little bit suspicious.
It's a trade, but not everyone is willing to do it. I did it with a dentist, but the recommendation was to have braces to correct a problem where teeth had got, and it was a year and a half stuff. My first reaction was, I'm never going to do that again. I did that when I was a kid. But when he explained to me the advantages and the strategy and all, and I said, I insist you do it. Then you become partners.
Well, the only correction I would have
Sure.
to that is convinced, because I think that becomes, in some ways, my point of view is going to go on you. So I think that partly what we're talking about is how do you create conversation with somebody that is a listening, building, kind of creative conversation. And I think that's where Vygotsky comes in, because I think there is, at least in Wittgenstein, which informs a lot of our understanding of conversation, is not a information exchange. It's a collaborative, creative word game that we're playing that creates something.
Well, usually there's something that will come in the middle of that, a misunderstanding of a phrase or a word. And you think it means one thing, and then by the dialogue, yes, you have to have a dialogue. Then you find out, oh, no, this particular word or concept really is something somewhat different, and then the person can view the whole thing differently. But you have to pass through these stations to get to that. So unless the train's running and there's stops provided on the stations, you can have it. So you want to make sure they're there.
Jessica?
You were saying in the beginning that these conversations are taking place, in inner city Brooklyn as well as in Brooklyn Heights. But would you say that there's a difference kind of across the socioeconomic spectrum of how these conversations take place? I was thinking that in poor communities, like where most people are on Medicaid, everything is so intervention driven that you're kind of like forced to do something or else you can't bill. You can't bill for it. And a lot of, I think, billing drives a lot of practice, particularly like in poor communities.
Well, I think there's that environment that you're working in, but I don't find that people in inner city communities are any less activistic. And they might be activistic in more which we call non-compliant ways. They don't. but I think people are very much engaged in what's happening to them, and in ways. And in some ways, I think what I I think we can teach people, and we try to do here, is how to have a better conversation around this. I mean, I presented at SHARE, which is the self-help group for women with ovarian and breast cancer, and a consumer-run organization, and very, very savvy women there who knew lots and lots more than I did about breast cancer treatment. But I was really surprised the number of people that the only thing they felt they could do when they had an interaction with the doctor that wasn't good was to walk out and to go to the next one. Or, and some of them had gone through 9 or 10 doctors because they're very educated consumers. But I think that's, I found that something that people could actually do something different with, and particularly as the consumer to say, hey, let's have a different conversation here. That we're participants in this. I think that goes back to the, hamburger chicken decision that you're making. I mean, these things seem so day to day, but I think that if we're not thinking, that's when, especially we need our philosophy, because I think that's when we need to be human actors in that activity.
I'd like to take a chance to respond to that also. I don't know if there's a difference in the quality of the conversation in terms of based on where, if it's in Brooklyn or at Abington, because I think the quality of the conversation is suffering across the board. All right. I mean, what Susan and I talk about in terms of the kind of I-thou relationship is not widely prevalent. Right? It's not widely prevalent. It's not, if you go out and you really push the agenda, and what's interesting to me is that people are asked about their own individual positions, so it's high satisfaction, but they hate medicine across the board, right? But I have, as a director of training, the opportunity to be with my faculty as well as my residents. And I'm telling you, what I hear uttered in the name of care is staggering. And we do all this videotaping. And, I can, bring up some videotapes if you want. But the bottom line is that, there's a lot that needs to be done. So I sent Susan, there's a report out of the Lucian Leap Institute. Lucian Leap is a very famous Harvard physician. It started really the quality movement in terms of outcome-based analysis in the mid-'80s. And now it's trying to push us to change the undergraduate medical education and also the graduate medical education. In what way? Well, it has to be learner-centered, which education isn't right now. They're pretty much employees as opposed to students. And it needs to be patient-centered in a much different way than it currently is. In terms of, and that's why I say I-it or I-you is the more dominant model as opposed to I-thou. What Lucian Leap's report would say, we have to get into the third model. We have to get, the secret in caring for the patient is caring for the patient. Right? It's the Francis Walt Peabody article and the 29 JAMA article. And actually, Aves Donabedian, who's the king of quality at the University of Michigan many years ago, was asked the secret to quality. It's love your patient. What the hell does that mean? What model is that? Love your patient is almost like, it's illegal. But it really has to be fundamentally different than what's going on. So whether you're in the clinic in Brooklyn, not Susan's clinic, or you're in my prior practice, right? The nature of the conversation really needs a lot to be decided.
Vicky? Yeah, I know.
Well, unfortunately, I have a lot of issues with doctors, but I get along with doctors. But the thing is, many moons ago, I had to have a breast biopsy. And they thought, oh my gosh, blah, blah, blah. Thank God it was negative. Then I went through mammography to the top radiologist many years later. And the radiologist said, oh, I have a little thing there, and I've got to get that taken care of. We made an appointment for me to put an isotope in the thing so that the surgeon could operate. I go to put the isotope in. I picked a different doctor for to put the isotope than the original one. That doctor said, I don't see any place to put the isotope. I said, Okay, they called in the head doctor there, and she's the top, one of the top in the city, with all the other doctors. And it was 4 against 1, the one who couldn't find the place to put it. So I canceled surgery and said, if he doesn't find a place to put the isotope, what am I going for surgery for? So I think it's a matter of doctors don't want to rat on the big doctor, and some of them go along with the things, and blah, blah, blah. And I chose not to. Of course, I got a bill from the hospital for the surgery I didn't have. But that's neither here nor there, I guess.
And I said all he wanted to do was cut.
And it's such a blind thing. I think you have to then go to someone in another office. When you have an instance like I had, 4 of them are saying, oh, go into the hospital, whatever. And one of them is saying, what are you taking out? There's nothing there. And he subsequently left that practice. And this was the top, one of the top in the city.
Well, I think probably many people have those stories, and I mean, my response to it is one of the reasons I find I want to do this is because I think those things happen all the time, and I wanted to ask Lou what he had his hand up, what you had to say, but also to ask the audience about what they thought they needed to make better decisions. Yeah.
Like for years I've gotten PSA screening, as a routine part of the, annual checkup. 10 years ago there was a bump in the number, and I was, advised to get a biopsy. I probably would not have done it, but my partner, who happens to be a former, was supposed to be here tonight, but she had a forthright. She's trained in medicine, not a practicing doctor. She pushed me to do it. I had the biopsy. Very unpleasant experience. Came back negative. Then this past year there was another bump in the PSA, so I was pressed to get another biopsy, and I said no way. But eventually I caved in and had one. It was more unpleasant than the first one. While I was in the waiting room, drinking a glass of orange juice, before you're allowed to go home, I was talking to a guy sitting next to me, and he told me that he was a guy who looked like about my age, maybe I think actually older, who looked terrific. He was like he looked like the healthiest guy of age I've ever seen. And he said he had had 12 prostate biopsies, and I said, what?
That's almost a prostatectomy, but.
Yeah, I said, do you have any prostate? Do you have any prostate left? He said, and they all came back. His PSA was like something like 60 or something, and he said all the biopsies come back, negative. So I said, I heard that, and I said to myself, I haven't shared this with my partner yet, but it's going to be a big argument when I do. But I said I'm getting off of this wagon right now. I'm not going to be screened. I'm not going to be screened anymore.
Can I ask how old you are?
64.
Yeah.
Well, I think that it's interesting because my friend back there, Kim Warren, and I actually went through this together and talking about it, and he decided not to get more biopsies, right? How many do you have? Gone. We presented at the medical school for the introduction to the first-year medical students at SUNY Downstate, I guess. He and I actually gave a discussion to the first-year students to sort of talk about how, where the patient comes into this formula, because there is sort of a automaticism, I call them. The protocols are such that you do this. If you have a bump in your PSA, you go for the biopsy. And so at some point you have to say, I'm going to stop the protocol. I'm going to stop the train here and get off, because I don't want to go through the next steps. And I think there's many aspects of medicine where that kind of thing goes on all the time with testing, which is, yeah.
I'm also interested, I know there's been like, there have been a number of, 2 made front page articles in the Times in the last year or so about new thinking of the screening process.
Mhm.
So, and I frankly, I read them very carefully, and I was glad they were supporting my position, but I actually wasn't sure I really got the point statistically, I got the point that they were making. Where they're saying it basically doesn't save any lives.
Mhm.
So,
And that's
Why suffer?
well, you know, it was there was an op-ed piece talking about the Times from the physician, and he was in Arizona now, who developed a PSA test. In an op-ed piece, he said, when I developed the test, and I looked at the data, the test should never be used for screening in the first place. That's interesting, isn't it? Yeah, he developed a test, said he argued vehemently that it should never be used as a screening technique, and it's actually a very bad screening test. It's unfortunately the only thing we have. There's been no data on digital rectal exams. I mean, that should, you know, that's one of those things that it's more barbaric, but as a good screening technique, it's woeful. It's woeful, W-O-E-F-U-L. There's no data that it has efficacy. So men who have rectal swallow, putting your finger in a rectum has no efficacy in detecting, right, and saving lives in terms of prostate cancer. And the Preventive Health Service Task Force has said that for years, but no one paid attention to it.
but that's like much less invasive than the biopsy.
Well, I mean, I'm not going to argue that rectal exams are much less invasive. My patients don't like them, but if there's no benefit, there's no reason to do it in the first place. So this idea that, well, it can't hurt you, and it might help you, there's no benefit. So right now, you are caught, I think, not, you know, uninformedly in a controversy that is reared again. And really, the protocol now is changing. Even the head of the American Cancer Society, this is unheard of, came out and said we probably shouldn't be doing prostate cancer screening. That I've never, in my life in medicine for 30 years, the ACS president has never said anything like that. And to say that is a pretty bold statement. And it gets a lot of credibility in my mind because he acknowledges that this really is a serious concern for men. And I feel bad. It's like hormone replacement for women. You know, we used to believe that worked. And then all of a sudden, you know, there's an explosion of information in terms of does it work? And, you know, they really weren't sound, but we were making that recommendation as if it was Bible. That's the idea about reasonable certainty and unreasonable certainty. That's an example where actually it was known that it probably wasn't all that efficacious based on direct clinical trials, but we pushed it. We pushed it, and I feel really bad about it. I treated lots of women with hormone replacement, but I think for no good reason.
Lots of subjective issues around that people weren't taking into consideration, both for and against. Wayne?
Yes, I was thinking, and sorry for my lateness, but I was getting my papers for my CAT scan.
Be very careful.
And thank you, because I'm listening.
Don't eat.
I'm listening because what I'm about to state is going to support what I'm just saying is what you said was that, in other words, we really need to know what is going on. And the statement I want to make first is that many times you go to the doctor and you take their word right away to state, this is it, and you're going for this, that. You never stop to say or qualify why you're going to take this, that, and what have you. And sometimes they say because you need it, or something of that nature. Instead of them, you need to give them an open-end question that they cannot give you a yes or no, but give you an understanding of what is what. In addition, if they cannot do that, then you need to walk. And today, with my CAT scan,
Wise advice. Listen to her advice.
my appointment with my CAT scan, I thought about it also, which I made a negative today, is that I didn't ask why is it necessary to have a blood test a week before the CAT scan.
Well, there's probably, if you need the CAT scan, there probably is a good reason for that if you're going to get IV contrast.
Yes, yes.
because it was probably for a kidney test. Because if
Yes,
you're going to get a CAT
exactly.
scan with
He
a
did say
contrast, we can really cause you a lot of damage if you have, a significant kidney deficiency. So there is a good reason for doing that,
Okay.
if you haven't had a recent fracture. So that's okay, and I think it's okay, it's good, you demonstrate. If you're going to have a CAT scan, you should be told why.
Yes,
What's
I
the
know.
likelihood, and, if there's a good reason, you should have it, right?
Exactly.
But the doctor ought to be able to articulate it. So if he says, because I said so, your advice about walking is a good
That's
piece of
right,
advice.
that's right. So that goes for anything, really.
Yeah.
Yeah.
Whenever they start you're loading up with all of these tests, why? Why do I need this? What is it for? And going back to this lady's question about people that are poor or what have you, many a time they are less informed and they feel intimidated to ask the doctor what is what.
I think that's true. People walk out, Mary, on video.
Well, I guess it's interesting to me because, I've worked with Susan for a long time, and I think that one of the things, I don't know that Susan knows this, but one of the things I think she's helped me to do as a person and a relative to illness is to be much more playful with it. And I was thinking in this conversation, like, that almost feels sacrilegious to say, because there's something about conversations about health and healthcare and that you're not supposed to. And I guess I thought, just in a way, speaking to us for a moment, it's striking to me that we're kind of having this conversation as if we have no collective issues with uncertainty. Because a lot of, I feel like, the reactions to the medical profession, and God knows, I know it's easy to dump on the medical profession and doctors, and I don't particularly want to do that. I think doctors have a hard job, and Lord knows they're in a difficult situation. But there is a way it feels like we're relating to them as if we want it to be more certain. But if you accept the premise that for the most part, it's an uncertain profession, which both of you were saying, and in some ways, maybe we don't want to hear that. But it seems like if you embrace that, then it seems like our performance needs to, we would have to give some hard thought to then how are we going to perform, and it seems in a sense unfair to go into it as if certainty was the bottom line, and then you can either just get angry or you can walk, or and again, I'm all for people deciding not to do things, but I think that I guess I'm just suggesting that perhaps philosophically we open it up a little bit more, coming back to Susan's questions about what we need, because I guess the other thought I had was, I think one of the things you taught me, Susan, is a lot, and particularly around testing, and I never quite get this right, but that's okay. But it's kind of like you're kind of always saying, well, if you do it, not only what is its impact on your life, but kind of are you prepared to then do what it is that the test results are going to kind of dictate. And if you're not, and that's not how you want to live your life, then don't do it. And I grappled with that some, but the more I've kind of been able to accept that, I realized that it's allowed me to lead with how do I want to live, and therefore, what's healthcare got to do with that, and that's one aspect of life, versus at some point it feels like the conversation gets very constrained by being afraid to die, or being afraid to be hurt, or being afraid to, you know what I mean? Like there's just a big difference between fully living your life and then deciding how you want your health care to be a part of that, and how quickly, particularly if you're in a health situation, it feels like it gets much more around, oh my God, how am I going, and that feels a little bit like the fight you're having with Lisa, like I know and I know, because I do a lot of work with my mom who's older, she's got health problems, and it's so easy to get caught up in, oh my God, she can't get hurt, but I've really tried to work with, okay, how are we going to live? So it feels like that's, I guess, part of the philosophizing, but perhaps opening up more broadly to a living life perspective, that being the frame within which this is this is happening, rather than the confines of the medical model, which is what it is.
David?
Yeah, that's very helpful, Mary. It also, to me, takes it out of just the doctor-patient relationship, or just the relationship between the patient and a whole bunch of doctors. I mean, I'm old enough to have a whole bunch of doctors now, you know. And I have to admit, I look at it more as a relationship. I have a lot of friends, too. Many more friends than doctors, thankfully. And you know, you can do certain things with some friends real well, and with other friends, with the same friend, you might not be able to have a particular kind of conversation, or, you know, you can't play racquetball with them, or whatever it is, you know. I kind of look at doctors the same way. You know, I mean, I've worked with Susan. I think Susan's a wonderful doctor, but there's no perfect conversationalist, and there are all these things we've all mentioned about the constraints. I mean, let's face it. Just look at it. If you want to do statistics, what percentage of the time are you in the doctor's office relative to your life, or relative to the history of the universe? You know what I mean? It's just like
2.3%.
there you go. So, just to say, and it is tricky, and I feel provoked by what you're saying, Mary. I mean, I dealt with my parents, both of them died recently. And we were able to have the kind of conversation, and even included a handful of doctors in it, relative to, was this about the quality of your life in the last several years of your life, or are we extending the number of years of your life? What are we doing here? You know, I feel I must have copped to a little reluctance doing that at age 58, as opposed to 78. But it is the same conversation, isn't it?
Yeah, I mean, I think the death issue that Mary brought is very much, so much a part of this. Well, what if I, you know, and you have to say, well, maybe that's what life is, you know, that's where it's going to. Alton had his hand up first, so and we have about 2 more questions, I'm afraid.
Is that Dr. Gary?
David Garrett, yeah.
Yeah, okay. You talked about marketing and information overload. These patients are, are going for these tests, and they have to make their antibodies, and maybe they didn't watch too much House episodes. Okay,
Be careful about House. If you have a physician who's like your House, you're in trouble.
I love that show.
Well, it's a great show, although it's terrible medicine. You have to understand, in fact, they were forced to get a medical consultant because the medicine was so bad. That it was, because the question is, how does the lay public know about medicine? Well, it's through shows like, ER, House, Grey's Anatomy. You guys think we have all this sex, in hospitals, right? It's not true. But that's where people get their knowledge, and that's a very dangerous thing. But go ahead,
Okay. But the issue here is, how do we get the patient and the doctor to agree that enough is enough? We're going to go ahead with this procedure. And Susan pointed out that we need a conversation, a dialogue with the patient, and to engender trust. To that regard, I think.
I'm a little, scrunching up my face because trust, it's kind of an abstraction. I think what you want to look for is,
Assurance.
no, I think you want to have a conversation where you and I have these all the time, and we don't make decisions. It could be 10 conversations. That's some way what I think is the activity which you started out. I think it's helpful for people to know that this can be an activity that is ongoing, is transformative, and might transform the illness as well as you go along. That you don't have to feel that obligation to come in point A, yes, no, yes, no. I mean, maybe if you have appendicitis and you're sitting in the emergency room, you'd have to make that decision, but that's hardly the typical case.
But you still have to reach a point where we have to go ahead with treatment and
Right. Now, medicine, by and large, is decision-making, because we don't have the luxury, like the philosophers, of sitting in the ivory tower and talking endlessly. So eventually the discussion has got to stop, right? and you got to make a choice. Either you do it or you don't do it, right? But here's the question that I think, and you raised it to some extent. I forget the videographer's name, but is what if Susan said to you, "I don't know," and really I don't think anybody knows at this point. We're going to have to at least look at the decision and say we're going to do the biopsy of the prostate or we're not, because there's no way. All the machinations of the world are not going to be done. Are we going to screen or biopsy or do any what you pick the decision, stress test of the heart. So at some level, you got to stop, right? And I do this all the time. I lose a lot of patients when I say this. If you say I don't know, you'll prosper. It's a famous old quote, right? And so if the patient can accept that, and can accept the irreducible uncertainty, and you make a choice, and there's not the post hoc regret. There's not the, you told me, I said basically it's a very difficult decision. We could go either way, because most decisions that have been analyzed are too close to call in the formal analytic sense. There's no good answer, right or wrong. So you make a choice, you go forward, and you can't look back, because in the moment, the choice you made was pretty informed. And there's lots of books out now in terms of how you make decisions, and it's not rational. It's not the formal sort of trade-off analysis with probabilities and utilities. That's not how we make decisions. So you got to do the best you can and move ahead, because there's no other recipe at this point in time.
One thing
This is the
that,
last question.
it's not a question. You asked what would we want from a doctor? One of the questions I will ask a doctor is, what would you do if it was your body, or what would you do if it was your wife's? I had one doctor who was very funny. He said, which wife? But seriously, I would want the doctor to share with me what they honestly believed in terms of the treatment. Not that I and why. Not that I necessarily had to do with it. It's like one of the issues for me is osteoporosis. I've been recommended several things. I refuse to take a Vista. Why? Because if you get a stroke, you're more likely to die, and my mother had a stroke. So that feels a little risky. I may not be right about this, but I would want a physician to say, well, this is, you have a big risk if you don't, and this is, get more information, but I would like them to tell me what they think, not just go along with what I think or try to deal with it, but I would like their honest opinion. But respect the fact that I may not come out with the same result. That's what I would want.
I think that's a good philosophy, is that you want some things, but they're not necessarily going to dictate to you. You're going to, in the bottom line, make that based on who you are.
But I would like them to really honestly tell me what they think and why.
Yeah, well, I think that's, I'm respectful of that.
But if you're going to ask me, if I was taking care of you, and you're going to ask me, it can't happen at the beginning of the discussion. It's got to happen after we have the kind of conversation in which we have a foundation of trust to go ahead, so I feel comfortable that you've heard things that are important, so that you can weigh what I say if it were me or my loved one. So it can't happen early on. You can't hurry love. You can't hurry the process of decision making. So there has to be some conversation going forward. All right?
Trust is a big word.
I think that's right.
You can create it. You can create it in 5 minutes. You can create it in 10 years.
Just one last question. I was wondering, what would you recommend in order to have, what kind of educations should patients and doctors have to get to that third level of, connection where trust and truth can be spoken?
Given where I'm from, I would highly recommend that people learn improvisation as performance, because I think it is a performance. That's what I think. And many people are here today who are in our improv group. So, but I think that that safety article, what I think that is lacking in the medical education has to be through something like performance and improvisation, because I think it is creating trust is a performance. It's a activity that doctors and patients are going to do together. So that is my answer. So you've been a wonderful audience. Let's give ourselves a hand.